So we all know ovarian cancer runs in the family, right? Which type of ovarian cancer runs in the family? Epithelial ovarian cancer. Okay, epithelial ovarian cancer runs in the family. So do we have to offer genetic testing for all women who develop epithelial ovarian cancer? The answer is yes. Okay, for all women who develop epithelial ovarian cancer, genetic testing has to be done. Okay, and what are the two important genetic syndromes which are associated with epithelial ovarian cancer? One is BRCA and the other one is HNPCC. Okay, so we'll now learn where to or who all to subject for familial risk assessment, the criteria for genetic testing. Okay, so what is the criteria for genetic testing? Okay, so we have 9 important points here. I want you to know all the 9. Okay, the first criteria here is epithelial ovarian cancer at any age. You understand my point? So, epithelial ovarian cancer at young age, I mean, students usually think that epithelial ovarian cancer at young age is likely to be hereditary. That's true, but that is not the only indication for genetic testing. Okay, even an epithelial ovarian cancer involving the postmenopausal woman warrants genetic testing. Okay, so epithelial ovarian cancer at any age. The second is breast cancer. Breast cancer diagnosed at age 45 or younger. Age 45 or younger. Okay. Next is breast cancer with 2 distinct and sequential primaries. The first one diagnosed at age 50 or younger. 2 distinct and sequential primaries need not be in the same breast. Okay, it can involve 2 different breasts or within the same breast 2 different foci. Okay, diagnosed at the age of 50 or younger. Okay, triple negative breast cancers diagnosed at less than or equal to 60 years. Okay, breast cancer at any age with at least one close relative diagnosed at or less than 50 years. Okay, then breast cancer at any age with 2 or more close relatives with either breast cancer or one close relative with epithelial ovarian cancer or 2 close relatives with pancreatic cancer or aggressive prostate cancer. All these are malignancies related to what? BRCA. Okay, so breast cancer at any age with 2 or more close relatives with breast cancer. Okay, or one close relative with epithelial ovarian cancer or 2 close relatives with pancreatic cancer or aggressive prostate cancer. Okay. So, the next is breast cancer with a close male relative. Breast cancer, okay, breast cancer involving a male relative. Age, any age, because males are very unlikely to develop breast cancer, right? So, male breast cancer at any age with breast cancer in the patient herself is an indication for what? Genetic testing. Okay. Next is breast cancer with Ashkenazi Jewish ancestry. So, you all know these Jewish people are at risk for BRCA mutations, right? So, next is individuals from a family with a known BRCA 1 or 2 mutations. Okay, so these are the 9 important indications for genetic testing for BRCA mutations. Okay, epithelial ovarian cancer at any age, breast cancer at less than or equal to 45 years, breast cancer with 2 distinct and sequential primaries, one after the other. The first one diagnosed at or less than 50 years, triple negative breast cancer less than or equal to 60 years, breast cancer with at any age with one close relative diagnosed at less than 50 years. So, next is breast cancer at any age with 2 or more close relatives with either breast cancer or one close relative with epithelial ovarian cancer or 2 close relatives with pancreatic cancer or aggressive prostate cancer. Male relative with breast cancer at any age, Ashkenazi Jewish ancestry and known BRCA mutations in the family. These are the indications for genetic testing. Okay. So, once you detect the patient to be either BRCA positive or Lynch positive, what are you supposed to do? You need to know the percentages of breast cancer and ovarian cancer in BRCA1 and BRCA2. Okay, so this is a very important MCQ area. Now, please remember. In various books, you will be seeing various figures like say 40 to 50%, 48 to 50%, 50 to 55%. Okay. Now, whenever it's a range, you make it a round value so that in the MCQ you can solve it easily. Now, what is the percentage of breast cancer associated with BRCA1? With BRCA1, it's 60%. I mean, I've made it a round value so that anything close to 60 can be picked as the answer. Okay. So, 60. In BRCA2, it's 50. And the risk of ovarian cancer in BRCA1 is 40 to 50. In BRCA2, it's 20. You understand? Okay. So, the risk of breast cancer is almost the same in BRCA1 and 2. There's no much difference. 60, 50. They're very close values. But the risk of ovarian cancer is, highly different for BRCA1 and BRCA2. In fact, I would say the incidence of ovarian cancer is in BRCA1 is twice the incidence of ovarian cancer in BRCA2. In BRCA2, the incidence of ovarian cancer is only 20%, whereas in BRCA1, the incidence of ovarian cancer is around 40 to 50%. Okay. So, very important MCQ area. Very important MCQ area. Okay. Risk involved in BRCA1, the incidence of malignancy in BRCA1 and BRCA2. Okay, fine. So, how are we going to proceed? What are we going to do to these women once they've detected to be BRCA positive? Okay. So, these women should be subjected for clinical breast examination right from the age of 25. Right from the age of 25, they're supposed to be subjected for what? Clinical breast examination every 6 to 12 monthly along with annual MRI. Okay, along with annual MRI. Okay. So, what are we supposed to do? Meaning, ovarian cancer is my part, right? So, what are we supposed to do to prevent ovarian cancer? Definitely prophylactic total abdominal hysterectomy with bilateral salpingo-oophorectomy, because both BRCA and Lynch mutations increase the risk of both endometrial and ovarian cancer. Okay. So, we're going to do a total abdominal hysterectomy with bilateral salpingo-oophorectomy, but when? That's the question. When? Okay. So, for BRCA1 mutations, this prophylactic TAH with BSO is supposed to be done between 35 and 40. Between 35 and 40. Very important MCQ. For BRCA2, prophylactic TAH with BSO is supposed to be done between 40 and 45. Between 40 and 45. And for Lynch syndrome, it is supposed to be done at 40. At 40. So, I would say the common answer for all the three would be what? Definitely 40 years. Okay. So, for BRCA1, it's 35 to 40. For BRCA2, it's 40 to 45. And for Lynch, prophylactic TAH with BSO is supposed to be done at 40. So, the common answer for all these would be, the single best answer would be 40 years. But if the examiner asks you how early should you do it, you understand the difference, no? How early should you do it? For BRCA1, the answer is 35. For BRCA2 and Lynch, how early will you do it? 40. But on an average, if, like say, when should a total abdominal hysterectomy with bilateral salpingo-oophorectomy done for genetic mutations, people with genetic mutations? The answer should be 40, roughly. Okay. If particularly BRCA1 is mentioned, then your answer will be 35. You understand? Fine. So, what is the protection offered by doing a prophylactic TAH with BSO in these women? Okay. Remember, prophylactic bilateral salpingo-oophorectomy only offers 96% protection against ovarian cancer. Okay. It is not 100% protection, it is only 96% protection. Why 96%? Why 96%? Why not 100%? Okay, that's because remember, they are not only associated with ovarian cancer but also associated with peritoneal cancer. That means, see, ovarian cancer is a malignancy that can either arise from the distal part of the fallopian tube, or ovarian epithelium, the cuboidal epithelium that surrounds the ovary, or peritoneum, the serosa. It can arise from either of these structures, and most often it arises from the distal part of the fallopian tube. Okay, where does it arise from? Most often it arises from distal part of the fallopian tube. You understand? So when you perform a salpingo-oophorectomy means what? Salpingo-oophorectomy. When you perform a salpingo-oophorectomy, salpingo is a word referring to the tubes. Oophorectomy is a word referring to the ovaries. So salpingo-oophorectomy means removing the tubes and the ovaries. When you combine it with TAH, total abdominal hysterectomy, it becomes complete removal of the uterus, tubes and ovaries, and that's what we perform here. TAH with BSO. That means the uterus, the tubes and the ovaries are removed. What is not removed here? Peritoneum is not removed. You understand? Of course, it's impossible to remove the entire peritoneum, right? Yes. So, there are possibilities that the lady would still develop malignancy, but the incidence will be very, very less, and it's only what? 4%. You understand my point? 4%. Why? Bilateral salpingo-oophorectomy offers 96% protection against ovarian cancer. Very important MCQ. 96%. So, regarding breast cancer, what percentage of breast cancers are prevented by doing a prophylactic salpingo-oophorectomy? Only 50%. Because by doing a salpingo-oophorectomy, by removing the ovaries, what do you cut off here? By removing the ovaries, you cut the source of estrogen and progesterone, which are two important hormones responsible for breast cancer. You understand? Hormones responsible for breast cancer are estrogen and progesterone, both. By removing the ovaries, you're decreasing the estrogen and progesterone levels in the body, and thereby it decreases the incidence of breast cancer. It will not be as effective as you do a mastectomy, but still doing a salpingo-oophorectomy would protect against breast cancer. To what percent? 50%. Very important MCQ. Okay. 50% protection against breast cancer, 96% protection against what? Ovarian cancer. Okay. So, yeah. The risk of familial ovarian cancer is high if first degree relatives have ovarian cancer. Definitely yes. If first degree relatives have ovarian cancer, the risk of ovarian cancer is high. Next option is this. One woman has ovarian cancer and a first degree relative under 50 years of age has breast cancer. Shall we see? One lady has ovarian cancer and a first degree relative has breast cancer under 50 years of age. Breast cancer at any age with at least one close relative diagnosed less than or equal to 50. So, it includes ovarian cancer as well, either breast cancer or ovarian cancer. Okay, so this is also correct. BRCA1 in the family history of BRCA1 definitely is a risk factor, no doubt. One woman has ovarian cancer and 2 degree relatives have breast cancer diagnosed before 60 years of age. One woman has ovarian cancer and 2 first degree relatives have breast cancer diagnosed before 60 years of age. Okay. So, coming to the risk factors of epithelial ovarian cancer. Okay, so whatever I am telling now is for epithelial ovarian cancer. Okay, what are the risk factors? Increased age, okay, increased age, personal history of breast cancer, family history of ovarian cancer, BRCA1 and 2 mutations, HNPCC, nulliparity, early menarche, late menopause. So, nulliparity, early menarche, late menopause, all these 3 are associated with what? High estrogen, unopposed estrogen. Okay. So, we all know actually ovarian cancer arises from the distal part of the fallopian tube. So, whenever there is unopposed estrogen, the fallopian tubal epithelium grows. Okay. So, there are all chances that it would undergo hypoplasia and at one point it would develop into malignancy. Okay. So, unopposed estrogen, like how it works for endometrial cancer, here again it works for epithelial ovarian cancer too. You understand my point? Apart from this, any repeated ovulation, because you know not only the fallopian tubal epithelium can contribute for epithelial ovarian cancer, but also the epithelium of the ovary proper, that is the cuboidal epithelium. Okay, so that means what? Repeated ovulations lead to damage to epithelium of the ovary and ultimately increase the risk of ovarian cancer. Okay, so there are two mechanisms by which ovarian cancer develop. Okay, one is unopposed estrogen, and the other is repeated ovulation. So, early menarche, late menopause, nulliparity. All these are related to unopposed estrogen, right? Infertility, ovulation induction drugs, endometriosis, all these are infertility and ovulation induction drugs. These two are related to what? These two are related to increased ovulation, because every time the lady gets pregnant, she doesn't ovulate for at least 9 or 10 months, right? And another 6 months for lactation. So, every pregnancy, each single pregnancy protects the woman against ovulation for 1 to 1.5 years. Yes or no? Yes. So, obviously infertility, nulliparity, all these are conditions where the woman keeps ovulating repeatedly. Yes. So, these increase the risk of epithelial ovarian cancer. Again, PCOS, endometriosis and HRT are again conditions with high estrogen. Okay. So, these again increase the risk of epithelial ovarian cancer. Okay. Personal and family histories are increased age, personal history of breast cancer, family history of ovarian cancer, Brca 1 and 2 mutations, HNPCC, and then hormone related. Okay. Hormone related risk factors are nulliparity, early menarche, late menopause, infertility, ovulation induction drugs, PCOS, endometriosis and HRT. Apart from this, certain other environmental habits, okay, certain other environmental factors are responsible for increasing the risk of ovarian cancer. They are cigarette smoking, talc exposure, and personal factors like high fat diet, obesity, PID, okay, pelvic inflammatory disease, obesity, high fat diet, talc exposure and cigarette smoking. So, cigarette smoking increases the risk of which type of ovarian cancer? Basically, smoking decreases the estrogen levels in the body. That is how smoking protects against fibroids and endometriosis, right? Smoking is one important factor. See, smoking is one important factor that decreases estrogen levels in the body. Okay. So, what does it do? It decreases the risk of fibroids and endometriosis. It in fact offers protection against preeclampsia too. Fibroids, endometriosis and preeclampsia. Okay. But remember, smoking increases the risk of cervical cancer. It increases the risk of cervical cancer, especially adenocarcinoma of the cervix. Okay. It also increases the risk of ovarian cancer. Which type of ovarian cancer? It is mucinous type of ovarian cancer, mucinous adenoma or mucinous adenocarcinoma. Okay. Why particularly mucinous adenoma or mucinous adenocarcinoma? Because mucinous adenoma or mucinous adenocarcinoma, the epithelium resembles cervical epithelium, endocervical columnar epithelium. You understand my point? In mucinous adenoma or mucinous adenocarcinoma, the epithelium resembles endocervical columnar epithelium, and that is why smoking increases the risk of both adenocarcinoma. It increases the risk of both adenocarcinoma of the cervix and mucinous type of ovarian cancer. You understand? Okay. So, these are the factors: PID, obesity, high fat diet, talc exposure and cigarette smoking increase the risk of epithelial ovarian cancer. There are 3 important factors which decrease the risk of epithelial ovarian cancer. What are they? Very, very important MCQ points. One is combined oral contraceptive, the next is hysterectomy, and the third is tubal ligation. Okay, combined oral contraceptive, hysterectomy and tubal ligation. 3 important MCQs, 3 important factors that protect against ovarian cancer are COC for obvious reasons, because COC decreases ovulation. No? Whenever you put the woman on combined oral contraceptive, what happens? She goes anovulatory. Yes? So, COC. Then comes hysterectomy. Obviously, when you do a hysterectomy, most of the time you remove the tubes. Okay? So, hysterectomy also offers protection against epithelial ovarian cancer. Why tubal ligation? Why tubal ligation? See, tubal ligation is a surgery where, supposing say this is the uterus and this is the fallopian tube. This is the fallopian tube and say this is the ovary. Okay. Now, tubes receive blood from both ovarian artery as well as uterine artery. You understand? So, tubes receive blood from both ovarian artery as well as uterine artery. Now, when you perform a tubal ligation, what do? You cut the tubes, no? Cut the tubes. Yes? So, when you do that, you not only anatomically detach the tube, distal part of the tube from the proximal part of the tube, but also compromise its blood supply. You understand? Whenever you cut the tube, the twigs that reach the tube from the ovarian and the uterine arteries are also cut. Okay. So, that means there is a decrease in vascularity. So, when there is a decrease in vascularity, there is an atrophy. You understand? Tubes atrophy. Okay. And this is one important reason for why tubal ligation protects against ovarian cancer. Okay. So, 3 important factors I have told you that offer protection against ovarian cancer, and they are combined oral contraceptives, hysterectomy and tubal ligation. Very, very important MCQ points. Okay. So, we will see one MCQ here. Regarding epithelial ovarian cancer, factors increasing the risk are. So, what is the effect of hysterectomy here? Hysterectomy decreases the risk. No, hysterectomy decreases the risk. Smoking increases the risk. Tubal ligation decreases the risk. Talc exposure increases the risk. PID increases, endometriosis increases, HRT increases, and combined oral contraceptive decreases. You understand? So, the odd ones are 1, 3 and 8. Hysterectomy, tubal ligation and combined oral contraceptives decrease the risk of epithelial ovarian cancer. Okay. So, the correct answer is all except 1, 3 and 8. Okay. So, here we finish the risk factors for epithelial ovarian cancer. Okay. So, we will now classify ovarian cancer. We will do the staging part and we will do the treatment part. Apart from this, I will tell you some important MCQs on the tumor markers. Okay. So, how do I classify? Based on the invasiveness, okay, I divide them into benign, borderline and malignant. Okay. So, you know what is benign, you know what is malignant. There is a unique type here called borderline variety. Borderline. Okay. Now, what's the importance of this borderline? Borderline is somewhere between benign and malignant. There are 4 important points to say that it is a borderline tumor, and I'll also tell you how it is different, in what way it's different from a malignant tumor. Okay. Point number 1, borderline tumor has mild increase in mitotic activity. Mild increase in mitotic activity means what? Whenever there is a gross increase in mitotic activity, it is malignant. Okay. Whenever there is no increase in mitotic activity, it is benign. Mild increase means somewhere between no increase and gross increase. So, mild increase in mitotic activity, mild increase in nuclear atypia. Mild increase in nuclear atypia. This is again a point which is somewhere between benign and malignant. If there is no increase in nuclear atypia, it's benign. If there is a gross increase in nuclear atypia, it's malignant. So here there is mild increase in nuclear atypia, mild increase in mitotic activity. Okay, there is epithelial hyperplasia. Epithelial hyperplasia. Okay, and the fourth important point is absence of destructive stromal invasion. Destructive stromal invasion. Where do you see stromal invasion? Tell me, in which type, or among the three, benign, borderline and malignant, which one is associated with stromal invasion? Malignancy, no? Malignancy is associated with stromal invasion. Here there is no stromal invasion. You understand? Mild increase in mitotic activity, mild increase in nuclear atypia, epithelial hyperplasia and absence of destructive stromal invasion. Please remember, stromal invasion is absent. It is absent. Is it okay? Yes? These are the 4 important characters of a borderline tumor. Okay? So, based on the histology, we divide them into serous, mucinous, clear cell, Brca, endometrioid. We all know, because this is a quick revision video. I am not elaborating on all these. Okay? So, we have 5 types. Now, I will tell you some important MCQ points associated with these 5 types. Serous, mucinous, clear cell, Brca and endometrioid. Okay? Among these, which is the most common? Among these, which is the most common? Remember, serous cystadenoma is the most common benign epithelial ovarian tumor, and serous cystadenocarcinoma is the most common malignant epithelial ovarian tumor. You understand? Among all the epithelial ovarian tumors, most common benign variety is serous cystadenoma, most common malignant variety is serous cystadenocarcinoma. Anyway, it's serous. Okay. Now, in turn, we have 2 varieties in serous. One is high-grade serous and the other one is low-grade serous. Okay. So, both of them arise from the fallopian tubal epithelium only. Okay. So, whenever it's serous, I told you, no, most of the ovarian malignancies arise from, the distal end of the tubal epithelium. Okay. So, here again, both serous varieties, high-grade serous as well as low-grade serous, both of them arise from where? They arise from the fallopian tubal epithelium. They arise from fallopian tubal epithelium. Okay. 2 important MCQs. Apart from these, also remember we have 2 other varieties called clear cell and endometrioid, no? Yes. Clear cell and endometrioid. Both of them arise from endometriotic lesions. You understand my point? This is again a very important MCQ. So, what all types arise from endometriotic lesions? I told you, when we discussed risk factors, you remember I told you endometriosis is a risk factor for epithelial ovarian cancer. Okay, endometriosis is a risk factor for epithelial ovarian cancer. So, clear cell and endometrioid are 2 important varieties which arise from endometriosis of the ovary. In fact, the most common site for endometriosis is ovary, right? So, endometriosis of the ovary, whereas serous varieties arise from the distal end of the fallopian tube. Okay. Mucinous have various sites of origin. There is no one specific site that you can mention. And you know, the mucinous type ovarian cancer resembles the cervical columnar epithelium or the bowel, columnar epithelium of the bowel. Okay, fine. So, which is the most common? Next question is, which is the most common? 70% of them are high-grade serous varieties. Okay, 70% of them are high-grade serous varieties, and that is the most common. Very important MCQ. Next comes clear cell and endometrioid. Each of them make around 10%, and the other 2, mucinous and low-grade serous, make around 5%. Okay, the question is, which is the most common? I have already told you, high-grade serous is the most common. Okay, fine. See, there is something called stick lesion. Stick. What is stick? I'll tell you. Stick is serous. Stick is serous, tubal, intraepithelial. Serous, tubal, intraepithelial cancer. Stick. Okay. So, which type of ovarian malignancy arises from stick lesion? That's the MCQ here. Which type of ovarian cancer arises from stick lesion? The answer is high grade serous. Okay. The type of ovarian cancer arising from stick lesion is high grade serous. Okay. Very, very important. Very important MCQ point. High grade serous. Okay, where do the other types arise from? They arise from borderline tumors. Like I told you, what is borderline? No, borderline endometrioid, borderline clear cell, borderline mucinous. All these are there from where the respective malignancies arise. So that means borderline need not always be borderline only. Borderline can further develop into invasive malignancy. Okay. So borderline, I can say borderline is a precursor for invasive malignancy. Not all borderline tumors turn malignant. Understand that. Not all borderline tumors turn malignant. Some of them end as borderline. Some of them turn malignant. I'll tell you the percentage. But for now, remember, stick lesions are serous tubal intraepithelial cancers from which high-grade serous epithelial ovarian cancers arise. Okay, fine. Now, the next question is this. We know there are certain epithelial ovarian cancers which run in the family, especially those who carry this Brca mutation and Lynch mutation. Yes? So, now the question is, which malignancy is related to Brca? Among the different histological varieties that we are reading now, which type is associated with Brca? Which type is associated with Lynch? Which type runs in the family? Yes? So, I'll tell you, please remember, high grade serous. High grade serous is associated with Brca. High grade serous epithelial ovarian cancer is associated with Brca. So, what do you understand? The one that runs in the family is more severe or less severe? What's your opinion? Yes, the one that runs in the family is more severe because it's high grade type. Okay, it's more severe. Okay, so Lynch is associated with endometrioid and clear cell types. Okay, so please remember, it is all Lynch means it's kind of a high estrogen statement because we know Lynch increases the risk of endometrial cancer. That is again purely estrogen dependent. Yes. So here again you see endometriosis is the predisposing factor for endometrioid and clear cell cancer, which is again estrogen dependent. You understand my point? So everything runs around estrogen here when it comes to Lynch. So you can remember it easily. Lynch is associated with endometrioid type of ovarian cancer and clear cell cancer. At the same time, it is also associated with endometrial cancer. And please remember, endometrioid and clear cell cancer, both of them arise from endometriosis of the ovary. You understand? Endometriosis of the ovary. Okay. So, last coming to mutations. Very important MCQ here. Where do we see the dangerous P53 mutations? P53 mutations are seen in high-grade serous cancers. Okay. Where do you see P53 mutations? P53 mutations are seen in high-grade serous cancers. Okay. So, where do you see P10 mutations? In endometrioid and clear cell cancers. Endometrioid and clear cell cancers. Where do you see KRAS and BRAF mutations? They are seen in low-grade serous cancers. So, these are not very important, but what is important is this. Okay. So, where do you see P53 mutation? P53 mutation is associated with high-grade serous cancer. High-grade serous cancer. So, based on this, we in fact divide the epithelial ovarian cancers into type 1 and type 2 epithelial ovarian cancer. What all come under type 1 epithelial ovarian cancer? Low-grade serous, endometrioid, clear cell, mucinous, Brenner and seromucinous. All these come under type 1 epithelial ovarian cancer. Okay, all these come under type 1 epithelial ovarian cancer. And what are the mutations associated? We just saw, no? Yes. So all these are type 1. Okay, now don't confuse this data with the type 1 and type 2 that you study in endometrial cancer. There in endometrial cancer, endometrioid variety is type 1. Rest all non-endometrioid varieties are type 2 like serous, clear cell, all these are type 2. But here it's little different, okay. The type 1 and type 2 in ovarian cancer and endometrial cancer are little different, little. Okay. So here, please remember, this is type 2. This is type 2. This is type 2. Okay. Rest all are type 1. Okay. High grade serous is type 2. Clear cell endometrioid, low grade serous mucinous all are type 1. Okay. And also remember, the type 1 varieties are associated with P10, KRAS and BRAF mutations, whereas type 2 is associated with P53 mutation. Okay. So I already told you this point. High grade serous is what is associated with P53 mutations. Very important MCQ point. Okay. Fine. So we'll move on to tumor markers now. What's the tumor marker for epithelial ovarian cancer? Tell me. The tumor marker for epithelial ovarian cancer is CA125. You all know this, no? The tumor marker for epithelial ovarian cancer is CA125. But remember, not all epithelial ovarian cancers secrete CA125. In fact, 50% of ovarian cancers in stage 2 have normal CA125. Okay. When the stage advances, like say in stage 1 disease, 50% of women with stage 1 disease have normal CA125 levels. Only 50% of women with stage 1 ovarian cancer have elevated CA125 levels. When the patient moves to stage 2 and stage 3, it further increases. Okay. So, CA125 is a very useful marker for advanced stages and for follow-up purposes, but not for diagnosing stage 1. You understand my point? Okay. Nextly, we have something called mucinous ovarian cancer, mucinous acidinoma and mucinous adenocarcinoma, which again is an epithelial ovarian cancer, right? But here, rather than CA125 being a marker, we have a different marker, and that is carcinoembryonic antigen and CA19-9. These are the two useful markers in mucinous ovarian cancer. Okay. What's the most important marker for epithelial ovarian cancers? It's CA125, except mucinous adenocarcinoma, where the marker is carcinoembryonic antigen and CA19-9. These are for epithelial cancers. Now, having started the discussion on tumor markers, I'll just finish the tumor markers for other varieties like germ cell and sex-cord stromal tumors. Okay. So, what's the tumor marker for embryonal cancer? The tumor marker for embryonal cancer can either be HCG or alpha fetoprotein. Okay, two markers are there. One is HCG and the other one is alpha fetoprotein. Okay, what is endodermal sinus tumor? So, embryonal cancer, endodermal sinus tumor, choriocarcinoma, dysgerminoma, all these are germ cell cancers. No, all these are germ cell cancers. Okay. Now, what's the tumor marker for endodermal sinus tumor? There are two tumor markers for endodermal sinus tumor. One is alpha fetoprotein, okay, and the other one is alpha-1 antitrypsin. Okay, one is alpha fetoprotein and the other one is alpha-1 antitrypsin. Okay, what's the tumor marker for choriocarcinoma? The tumor marker for choriocarcinoma is HCG. HCG. Okay, what's the tumor marker for dysgerminoma? It is LDH and placental alkaline phosphatase. LDH and placental alkaline phosphatase are tumor markers for dysgerminoma. Okay, and finally, what's the tumor marker for granulosa cell tumor? The tumor marker for granulosa cell tumor is it estrogen? Because it's estrogen secreting tumor, you all know it secretes estrogen, right? Is estrogen a tumor marker for granulosa cell tumor? No. Because estrogen is non-specific. No, we cannot use it as a tumor marker. Anti-Mullerian hormone and inhibin B. Okay. See, it secretes both inhibin A and inhibin B. But inhibin B well correlates with the size of the tumor and the prognosis. So, we use inhibin B as a tumor marker rather than using inhibin A. You understand my point? So, what are the two important tumor markers for granulosa cell tumor? One is AMH and the other one is inhibin B, where inhibin B is the most important. Inhibin B is the most important answer. You understand my point? Okay. So, here what all do we have? Very, very important chart, very important MCQ. Tumor markers, please remember. Very, very important MCQ area. Tumor markers. Okay. So, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 tumor markers here. We have 12 tumor markers. Okay. What are they? For epithelial ovarian cancer, it's CA125. For mucinous variety of epithelial ovarian cancer, it's CEA and CA199. Embryonal cancer, HCG and alpha-fetoprotein. Endodermal sinus tumor, alpha-fetoprotein and alpha-1 antitrypsin. For choriocarcinoma, it's HCG. For dysgerminoma, it's LDH and placental alkaline phosphatase. For granulosa cell tumor, it is AMH and inhibin B. Is that fine? Okay. So, let's move on to the staging part. Now, we have to discuss the staging part. Okay. Now, though I have written all the stages here because it's a quick revision video, I will just highlight on those points which are likely to come as an MCQ. Okay. So, stage 1, you all know stage 1 means it's either limited to the fallopian tube or the ovary, because here fallopian tubal cancer, ovarian cancer and peritoneal cancer together come under one staging and one treatment. Okay. So, the staging and the treatment part for all these are just the same. Okay. So, what is stage 1? Stage 1 means it's limited to either the ovary or the fallopian tube. Okay. Fine. So, what is 1A? 1A is where only one ovary is involved. One ovary or one fallopian tube. Okay. Here both ovaries. Fine. And in both these cases, 1A and 1B, the capsule of the tumor will be intact and there will be no ascites, especially no malignant ascites. Okay. The capsule of the tumor will be intact, no capsular involvement. Okay. So, 1A is one ovary, involvement of one ovary. 1B is involvement of both the ovaries. What's 1C? 1C is where we have C1, C2, C3. And among this, the MCQ area is this. What is C1? C1 is surgical spill. Very important MCQ. Okay, like say you're operating on the patient. Okay, the capsule was intact when you opened. The tumor was huge. See, the tumor was 10 centimeter or 15 centimeter. And you couldn't take the tumor out through the incision that you have made, and in an attempt to remove the tumor intact, you inadvertently you ruptured it. Okay, that's C1, surgical spill. Okay, unexpected rupture, intraoperative rupture. Okay, now if the tumor is already ruptured, if the tumor is already there involving the capsule of the ovary, then it comes under C2. Okay, what is C3? C3 is malignant cells in ascitic fluid. Malignant cells in ascitic fluid or peritoneal washings. That means, what do you understand? When you perform a surgery, whenever there is ascites, you have to send the ascitic fluid for cytology to see if the ascitic fluid has malignant cells, or if ascites is not there, you have to give a peritoneal wash with 50 ml to 100 ml of normal saline and then send the fluid for cytology. The peritoneal washings, you have to, whatever saline you have put in, you have to take it and send it for cytology to see if there is peritoneal involvement. You understand my point? Okay. So, what are the MCQ areas here? 1A, 1B is very easy, one ovary, both ovary. 1C only you have two important MCQs. What are they? C1 is surgical spill, very, very important MCQ. C1 is surgical spill, C3 is malignant ascites. Two MCQs. C1 is surgical spill and C3 is malignant ascites. Okay, stage 2 is very easy. Stage 2 is from the fallopian tube or the ovary, it has extended to the uterus. Okay, or other pelvic structures like bladder, peritoneum and all that. This is not an MCQ area, okay, just forget. Now, coming to stage 3 and stage 4, here you have valuable MCQs. What is stage 3? Stage 3 is involvement of extrapelvic peritoneum. Extrapelvic peritoneum, I am stressing on this point because if the pelvic peritoneum is involved, it is stage 2. If the pelvic peritoneum is involved, it is what? It is stage 2. Okay. So that means stage 3 is involvement of extrapelvic peritoneum or retroperitoneal lymph nodes. Okay. What do you mean by retroperitoneal lymph node? Pelvic and para-aortic node. Okay. Retroperitoneal lymph node means pelvic and para-aortic node. Okay. In turn, in this we have A1, A2, B and C. What is A1? The retroperitoneal nodal involvement is A1. Okay. Retroperitoneal nodal involvement is A1, and remember both pelvic and para-aortic node fall under A1. This is a very important MCQ. Now again I am stressing on this point. You know why? Because see, in cervical cancer and endometrial cancer, the node that is mainly involved is pelvic node, after which comes para-aortic node. Okay. Now there is a sequential involvement, number 1, and that's because the artery that supplies the endometrium, the artery that supplies the cervix is uterine artery, and uterine artery is a branch of internal iliac artery, which is a pelvic artery, and therefore pelvic nodes are likely to be involved. There is no direct supply from the para-aortic node except for few parts of the fundus of the uterus, which ovarian vessel, which is a branch of aorta. Okay, see, what is the main blood supply for cervix and endometrium? It is from the uterine artery, which is a branch of internal iliac artery. Okay, and the cervix and the endometrium also receive its blood from ovarian artery, which is a branch of aorta. Okay, abdominal aorta. So which is the main artery supplying the uterus? The main artery supplying the uterus is uterine artery, not ovarian, uterine artery. Okay, most of the uterus is supplied by uterine artery. Then therefore, which node is likely to be involved? The nodal involvement follows the arterial supply, no? So because it's the pelvic artery which mainly supplies the uterus, the nodes that are involved are mainly pelvic more than para-aortic. Pelvic more than para-aortic. Okay, but when it comes to ovary, the main artery that supplies the ovary is ovarian artery. The main artery that supplies the ovary is ovarian artery, which is a branch of aorta. But ovaries also receive their blood supply from uterine artery, which is a branch of internal iliac. Okay. So for cervix, it's pelvic more than para-aortic, whereas for ovary, both are important, where para-aortic is more important. Para-aortic is more important because the blood supply is like that. The blood supply is directly from the aorta. You understand my point? Okay. So for this reason, when you stage cervical cancer and endometrial cancer, okay, when you stage cervical cancer and endometrial cancer, in cervical and endometrial cancer, pelvic nodal involvement falls under 3C1, para-aortic nodal involvement falls under 3C2. Pelvic nodal involvement is 3C1, para-aortic nodal involvement is 3C2. Okay. But when it comes to ovarian cancer, both pelvic and para-aortic fall under 3A1. Okay. Both pelvic and para-aortic. Both pelvic and para-aortic fall under 3A1. You understand? Yes. So this is about the nodal involvement. So here the most important MCQ is, what is 3A1? It involves pelvic and para-aortic nodes. A to B and C are peritoneal mets, where A2 is microscopic peritoneal met. Okay, A2 is microscopic peritoneal met. B is macroscopic peritoneal met up to 2 centimeter. C is macroscopic met more than 2 centimeter. Okay, so this is it. Fine. So when I say peritoneum, the capsule, the liver capsule, the splenic capsule, okay, all these come under peritoneal involvement. So if the capsule of the liver is involved, or if the capsule of the spleen is involved, what stage does it fall under? It falls under, yeah, either 3A2 or 3B or 3C, depending on the size. The liver capsule has a microscopic met, it is 3A2. If it has a macroscopic met measuring less than 2 centimeter, it's 3B, more than 2 centimeter, it's 3C. Very simple. Okay, so finally what is stage 4? Stage 4, A is again an MCQ area, very important MCQ. This is again an MCQ area. Pleural effusion with positive cytology, malignant pleural effusion. Otherwise, I would say malignant pleural effusion is 3. Malignant pleural effusion is 4A. Malignant pleural effusion is 4A. What is 4B? Whatever is not included in stage 1, 2, 3 and 4A will fall under 4B. So, obviously, any solid organ involvement in the abdomen, okay, like say parenchymal liver involvement, parenchymal splenic involvement, parenchymal lung involvement, all these are 4B, okay, all these are 4B. But capsular involvement, it comes under stage 3, like say liver capsule, splenic capsule, all these are stage 3, okay. Parenchymal liver mets and parenchymal splenic mets, all these are 4B. Similarly, pelvic and paraaortic nodes fall under 3A1, whereas inguinal nodes, very important MCQ point, inguinal nodes fall under 4B. Okay, inguinal nodes fall under 4B. Okay, so quickly I will tell you the MCQ areas. Surgical spill is 1C1. Malignant ascites is 1C3. Okay, pelvic peritoneum stage 2. Extra pelvic peritoneum stage 3. Okay, pelvic and paraaortic nodes both fall under 3A1. Okay, visible peritoneal mets either 3B or 3C. Okay. If that visible peritoneal met is less than 2 centimeter, it's 3B, more than 2 centimeter, it's 3C, okay. Liver and splenic capsular involvement, 3B or 3C depending on size, okay. Pleural effusion, malignant pleural effusion, 4A. Malignant ascites is 1C3. Malignant pleural effusion is 4A, okay. Finally, inguinal nodal involvement, 4B. You all understand, no? Yes, so this is about staging part. Now we will discuss the treatment part. Treatment part, we have separate treatment for borderline tumors and for frankly malignant tumors. I will tell you how to treat. So first of all, how do we stage the disease? How do we stage the disease? Do we use investigations mainly to staging? No. Staging itself is done during surgery. Okay, staging itself is done during surgery and the procedure is called a staging laparotomy. The procedure is called as staging laparotomy. Staging laparotomy. Okay. So if you have to stage, just think and tell me what all structures do you have, do you have to study here? Yes. See, definitely you have to remove the uterus and the fallopian tube and the ovary. Yes. So TAH with BSO is definitely a part of it. TAH with BSO is definitely a part of it. Why? Because uterine involvement is stage 2. Uterine involvement is stage 2. So you have to see whether one ovary is involved or both ovaries are involved. One ovary or both ovaries are involved. So for that you need to remove the tubes and the ovaries. And that will come under stage 1A or B. Right? Apart from this, malignant ascites. Malignant ascites is what? 1C3. No. So definitely you have to take the ascitic fluid for cytology. You have to take the what? Ascitic fluid. For cytology, if there is no ascitic fluid, what would you do? Peritoneal washings. You have to take the peritoneal washings, right? So if ascitic fluid or peritoneal washing is positive for cytology, positive for malignant cells, what stage does it fall under? 1C3. It falls under 1C3. No? Okay. So next is, okay, yeah. Next is this one, peritoneum and nodes. What is stage 3? Stage 3 involves retroperitoneal nodes and extra pelvic abdominal peritoneum. Okay. So definitely you have to remove the nodes. Yes or no? You have to remove the nodes, both pelvic and para-aortic lymphadenectomy. Pelvic, para-aortic lymph node dissection. Yes. To detect which stage? This is to detect stage 3A1. This is to detect stage 3A1. Peritoneal washing is for what? Peritoneal washing or ascitic fluid is for stage 1C3. It's for 1C3. Okay. So you perform a total abdominal hysterectomy with bilateral salpingo-oophorectomy to see stage 2, which is uterine involvement, stage 1AB, which is ovarian involvement. Ascitic fluid and peritoneal washings you do to detect stage 1C3. Okay. Nodes you have to remove. Nodal dissection you have to do to detect 3A1. Okay. Next is peritoneal biopsy. Peritoneal biopsy in suspected areas and infracolic omentectomy. Infracolic omentectomy, what is it for? In which stage do you have peritoneal involvement, microscopic peritoneal involvement, macroscopic peritoneal involvement? Where do they come? 3, A, 2, B and C. Okay. So this is basically to detect 3, A, 2, B and C. Okay. Fine. If there is pleural effusion, you have to tap the pleural effusion and send it for cytology, and that will detect 4A. Okay. So apart from this, any visible met which is more than 1 centimeter should be removed. Okay. Any visible met, all visible metastasis measuring more than 1 centimeter should be removed. Okay. So I have written few important points here. All these together make it a complete surgical staging. So staging laparotomy. Okay. So what all should you perform? What all should you do in a staging laparotomy? Total abdominal hysterectomy, bilateral salpingo-oophorectomy, ascitic fluid or peritoneal washings for cytology, nodal dissection, pelvic and para-aortic lymph node dissection, peritoneal biopsy, infracolic omentectomy, and remove all visible mets measuring more than 1 centimeter. This is complete staging laparotomy. So here the question is, only after you do all these procedures, you will come to know what stage it is. Okay. But in very young patients where you are planning to preserve one ovary or you want to preserve uterus for fertility purposes, there you can try to kind of assume the stage with investigations. But otherwise, definitely the stage is conclusively proven, like the stage is confirmed only after staging laparotomy. You understand my point? So now the question is whether we have to perform the staging laparotomy for all patients, or there are certain exceptions where we can offer a minimally invasive surgery. Okay, I'll tell you. Fine. Before that, see this MCQ. Which of these is the most frequent location for epithelial ovarian cancer spread? The route of spread. Okay. Which is the most common route of spread? The most common route of spread is omentum. You understand? Very important MCQ point. The most common route of spread is omental spread. Whereas for cervical cancer, it's direct spread. Okay. From the cervix, it directly goes to the vagina, it directly goes to the parametrium. But here, it mainly spreads through the peritoneum, which is otherwise the omentum. Okay. So, coming to the treatment part. Okay. How do we treat? The treatment is different for borderline and for frankly malignant tumors. Okay. Now, if you ask me, should we perform a complete surgical staging laparotomy for a borderline tumor? The answer is partly yes, because the procedure that we perform for a borderline tumor is little different from the one we perform for a frankly malignant tumor. And when I say little different, it means we are not going to perform pelvic and para-aortic lymph node dissection. in borderline tumor, whereas lymph node dissection is mandatory when you handle a case of malignancy, frankly malignant tumors. You understand my point? Okay. So, what are we going to do for borderline tumors? For borderline tumors, we will see whether the patient has already completed family or she hasn't completed family. Okay. So, if the patient has already completed family, you don't have to wait. You can perform a total abdominal hysterectomy, bilateral salpingo-oophorectomy. You can also perform omentectomy, and if there is ascites or peritoneal fluid, you can take it and send it for cytology, and then you can stop there. What you can skip is lymph node dissection. You understand? What you can skip is lymph node dissection. So, if this is staging laparotomy, you have various steps in staging laparotomy, no? TAH with BSO, ascitic fluid, nodes, peritoneal biopsy, omentectomy and METs. So, here METs are not going to be there if it's borderline, okay. Otherwise, peritoneal biopsy, yes, that means omentectomy, yes, you have to do. Ascitic fluid for cytology, yes, you have to do. If at all ascites is not there, peritoneal washing, yes. Total abdominal hysterectomy, bilateral salpingo-oophorectomy, yes, you have to do. What you can avoid doing is lymph node dissection. Very, very important MCQ point, okay. But if the patient has not completed her family, okay, if she has not completed her family, and if you want to do a fertility sparing surgery, if you want to do a fertility sparing surgery, if you want to do a fertility sparing surgery, then what you can do is unilateral salpingo-oophorectomy, preserving the uterus and the opposite tube and ovary, okay. Unilateral salpingo-oophorectomy can be done and the opposite tube and ovary can be preserved. You understand my point? If she hasn't completed her family, okay, and you can follow the patient up, okay. Now, the question is, see, you cannot perform a biopsy on any patient who comes with an ovarian mass because you have to avoid spillage. Yes, you can't perform a biopsy. So, you will come to know whether it's borderline or malignant or benign only when you operate on the patient. Of course, you can do a CA125 assay and you can calculate what is called as RMI, but that is not confirmatory, okay. That is not confirmatory for either borderline tumor or malignant tumor. So, only when you operate and if only when you study this specimen under the microscope, you will come to know whether it is borderline or frankly malignant. So, when you perform a surgery, how will you really decide on what to do? Whether to do a complete surgery, whether to do a pelvic para-aortic lymph node dissection or whether to do a fertility preserving surgery, how will you decide on that when you really do not know whether it's borderline or frankly malignant? You understand my question? Yes, the answer is frozen biopsy. The answer is what? Frozen biopsy. So, you know what is frozen biopsy, no? Yes? In the intraoperative period, you send the specimen for a biopsy where the pathologist will read the specimen and tell you whether it is likely to be borderline or malignant. When you are still operating on the patient, you call it frozen biopsy, okay. So, you perform a unilateral salpingo-oophorectomy for any woman who wants to preserve her, uterus, who wants to, who's desirous of future pregnancy. So, you first perform a salpingo-oophorectomy and send the specimen for histology, and the pathologist will tell you whether it is borderline or frankly malignant in the intraoperative period, and then you can decide on whether to remove the uterus and the opposite ovaries, whether to perform a lymph node dissection or whether to perform omentectomy or whether to just spare, whether to stop there, okay. So, this is about the treatment of borderline tumors, okay. Next, we will discuss the treatment of frankly malignant tumors. Frankly malignant tumor is where you have to perform a complete staging laparotomy, and you know what all are included in a staging laparotomy. Yes, TAH with BSO, peritoneal washings or ascitic fluid for biopsy, infracolic omentectomy and pelvic and para-aortic lymph node dissection, peritoneal biopsies. All these are supposed to be performed for any frankly malignant tumors. Whenever you don't suspect a borderline tumor, the treatment will be frankly malignant, staging laparotomy, complete staging laparotomy. But here again, if the woman wants to preserve her uterus, like say if she wants to retain her reproductive function, she hasn't completed her family, what can you do? Say say for a young girl, like say 22, 23, unmarried girl comes with malignant ovarian tumor where you want to preserve the uterus, yes, there are fertility sparing options here, and that fertility sparing option is what I'm going to explain now. Okay, so if the patient wants fertility preservation, what you can do is perform all other whatever step comes in this staging laparotomy, okay, like say peritoneal washings, ascitic fluid, peritoneal biopsy, omentectomy, pelvic and paraortic lymph node dissection, everything should be done. But the only thing that is different from a frank staging laparotomy is a bilateral salpingo-oophorectomy versus unilateral salpingo-oophorectomy. If you really think it's stage 1A, okay, if you really think it's stage 1A, or it's more likely to be stage 1A, okay, and if you really want to preserve her uterus, yes, you can perform unilateral salpingo-oophorectomy, okay. You can perform what? Unilateral salpingo-oophorectomy, and the question is, where can you perform this unilateral salpingo-oophorectomy? Obviously in stage 1A, because stage 1B is where both ovaries are involved. So obviously you have to remove both the ovaries. There you can't remove one ovary and you can spare one ovary, okay. So only for 1A, you can perform what? Unilateral salpingo-oophorectomy. From 1B onwards, you have to perform a bilateral salpingo-oophorectomy, and from 1C onwards, you have to perform a complete staging. Complete staging means TAH with BSO with all the biopsies that I told you, okay. Now after this, after you perform this surgery, staging laparotomy, you will be very much sure about what the stage is. And then you have to decide on whether to give adjuvant chemo for the patient, okay. Now where should you give chemo, where can you skip chemo? That's the next question. The first question was what? Where can you perform fertility sparing surgery, where you cannot perform a fertility sparing surgery, okay. For 1A, you can perform a fertility sparing surgery. From 1B onwards, both ovaries should be removed, okay. But chemotherapy, it's little different, okay. So where should you give chemo, where should you avoid chemo? Stage 1AB, grade 1 and 2. Stage 1AB, grade 1 and 2 is where you can avoid chemo, okay. Don't get confused, children, don't get confused. Where can you perform unilateral salpingo-oophorectomy? 1A. Where can you avoid adjuvant chemotherapy? 1AB. You understand? I'll write it here. Unilateral salpingo-oophorectomy. Where can you perform? Only in stage 1A. All other stages, anything more than stage 1A, you have to perform a total abdominal hysterectomy with bilateral salpingo-oophorectomy as a part of staging laparotomy. Okay, this is one question. The next question is, where can you perform? So that unilateral salpingo-oophorectomy is the fertility preserving treatment that I am talking about. Fertility preserving treatment. So fertility preserving treatment can only be done in stage 1A. Okay. Now the next question is, where can you avoid chemotherapy? Where can you avoid chemotherapy? This is the next question, and the answer is only in stage 1A, B, grade 1 and 2. So we have grade 1, 2 and 3. If that stage 1A, B fall under grade 3, then chemo is required. If it falls under 1A, B, grade 1, 2, then you can avoid chemo. You understand my point? For all other stages, adjuvant chemo is required. Okay. So these are two important MCQ points. Okay. Two important MCQ points. Where can you do fertility preserving surgery? Where can you avoid chemo? Is that okay? Fine. So here, this is it. Stage 1AB, grade 1 and 2, avoid chemo, observe, only observe. If it's high grade 1AB, that means high grade means grade 3. Grade 3 1AB or any 1C. 1C, grade 1 or grade 2 doesn't matter. All 1C should be treated with adjuvant chemo. Okay. Which drug to choose? I'll tell you. Okay. So, here you have to give adjuvant chemo for all other stages. So, here we are talking about only stage 1, no? Stage 1, A, B, C we have discussed. For all other stages, okay, for all other stages, what we're going to do is this. If optimal cytoreduction is possible, okay, if optimal cytoreduction is possible, then you do primary cytoreduction. That means before giving chemo, you give primary cytoreduction means what? You perform a staging laparotomy and remove all visible tumors more than 1 centimeter. That's cytoreduction, optimal cytoreduction. Okay. So, primary cytoreduction means, I'll explain. Cytoreduction, okay, means what? Optimal cytoreduction means perform a complete staging laparotomy. Complete staging laparotomy plus remove all visible Mets more than 1 centimeter. You understand my point? Okay. This is optimal cytoreduction. Okay. Whatever comes in staging laparotomy like total abdominal hysterectomy, bilateral salping oophorectomy, lymph node dissection, omental biopsy, fluid for cytology, all these should be performed. In addition to that, wherever you see metastasis, all metastasis should be removed. All Mets measuring more than 1 centimeter should be removed. This is optimal cytoreduction. Okay. Now, why am I explaining this? Because if you think cytoreduction can be done, it's not involving any major part of the bowel or major part of the, if it is not involving like parenchyma of the liver or parenchyma of the spleen, which is not amenable for resection. Okay. And if you're very confident that a cytoreduction can be done, an optimal cytoreduction can be done, you go for primary cytoreduction. Primary cytoreduction means before chemo. Okay. Perform the surgery before chemo and then give adjuvant chemo. Okay. If you think optimal cytoreduction is not possible, then you're supposed to give neoadjuvant chemo for 2 to 4 cycles and then do a secondary or interval cytoreduction. Okay. So, what is interval cytoreduction? When you do the cytoreduction after chemotherapy, after neoadjuvant chemotherapy, it becomes interval cytoreduction and then you do adjuvant chemo, another course of adjuvant chemo for 3 to 6 cycles. So, this is how we are going to treat stage 2, 3, 4. Okay. For stage 1, we are going to either perform a fertility preserving surgery or we are going to perform a staging laparotomy, and depending on the stage and the grade, we are going to decide on whether the woman should be treated with adjuvant chemo. If it is stage 1A, grade 1 and 2, no chemo. If it is stage 1AB, more than grade 1, 2, that means grade 3 or stage 1C, give adjuvant chemo. For stage 2 to 4, see the possibility of offering optimal cytoreduction. If you can offer optimal cytoreduction, just go for primary surgery, primary cytoreductive surgery, which includes staging laparotomy and clearing all visible Mets more than 1 centimeter, and then give adjuvant chemo. Okay, 6 cycles of adjuvant chemo. If you think it's not possible, okay, if you think it is not possible, like optimal cytoreduction is not possible, give neoadjuvant chemo and then interval reduction and then adjuvant chemo. Is it okay? Fine. What are the drugs used for chemotherapy? The drugs used for chemotherapy are carboplatin, paclitaxel, bevacizumab and Parp inhibitors. I'll tell you a few MCQ points on Parp inhibitors. Before that, please remember carboplatin, paclitaxel. These are the 2 main drugs. Okay. These are the 2 main drugs, and the most important point here is you can either give them IV or you can give them intraperitoneal. Okay. So, for which pelvic malignancy, for which gynec malignancy do we use intraperitoneal chemotherapy? Very important MCQ. Intraperitoneal carboplatin can be given for ovarian cancer. Okay. For which malignancy do we give intraperitoneal chemotherapy? Answer is CA ovary. Okay. Something about Parp inhibitors. What are Parp inhibitors? Parp is poly ADP ribose phosphate. Parp is poly ADP ribose phosphate inhibitors, Parp inhibitors. Okay, what all drug come under this group? This includes, these Parp inhibitors include olaparib, okay, niraparib and rucaparib. Okay, these Parp inhibitors include olaparib, niraparib, rucaparib. Okay, so what's the importance of these Parp inhibitors? Remember, these Parp inhibitors work well on Brca mutant patients. Okay, these Parp inhibitors work well on Brca mutations. Okay, malignancies related to Brca mutations. Okay, so very important MCQ point. What are Parp inhibitors? Poly ADP ribose phosphate inhibitors. Okay, in which malignancy do we use Parp inhibitors? Ovarian cancer. What are the drugs here under Parp inhibitors? Olaparib, niraparib and rucaparib. Okay, what's the speciality of these drugs? They work well on genetic cancers. They work well on cancers which run in the family. They work well on Brca mutant patients. You understand? In which gynec malignancy do we use intraperitoneal chemotherapy? Ovarian cancer. Okay, so these are few important MCQ points under chemotherapy. You should also know what is platinum sensitive, platinum resistant, platinum refractory. Okay, platinum sensitive is what? If there is relapse after 6 months of completing chemotherapy. I mean, after 6 months of carboplatin therapy, if there is a relapse, it is platinum sensitive. Okay, and if that happens within 6 months, of completing chemotherapy, it is platinum resistant. If the same happens while on chemo, if the disease progresses while on chemo, it's platinum refractory. If the disease progresses after 6 months of completing chemotherapy, it's platinum sensitive. If the disease progresses within 6 months of completing chemotherapy, it's platinum resistant. Okay, if the disease progresses while on chemotherapy, it's platinum refractory. 3 important MCQs. Okay, platinum sensitive, platinum resistant and platinum refractory. Okay, so this is about chemotherapy. And lastly, before finishing, I'll tell you something on the epidemiology. Okay, about ovarian cancers. So, what is the average age at diagnosis of ovarian cancer? The average age at diagnosis of ovarian cancer is 60. The average age at diagnosis of ovarian cancer is 60. But this is for frankly malignant ovarian cancers and not for borderline tumors. Okay, this is not for borderline tumors. Okay, what is the average age at diagnosis for borderline tumor? For borderline tumor, the answer is 46 years. Okay, the average age at diagnosis of borderline tumor is 46 years. And these borderline tumors constitute 10 to 15% of all epithelial malignant tumors, epithelial tumors. Okay, so what is the recurrence rate in borderline ovarian tumor? The recurrence rate is 10%. The recurrence rate is 10%. And what is the malignancy rate in borderline ovarian tumor? It's 20 to 30%. Okay, so when I discussed, I told you, borderline can turn malignant. Yes. And what are the ovarian tumor types of ovarian tumors which develop from borderline? The first one, that is high grade serous, develop from stick lesions, serous tubal intraepithelial cancers, and clear cell endometrioid, all these develop from borderline tumors. Okay, so the malignancy rate in borderline tumor is 20 to 30%, and they can arise in benign cystadenomas. Okay, serous cystadinoma turning serous adenocarcinoma, mucinous adenoma, turning mucinous adenocarcinoma. In between comes borderline. Okay. Are tumor markers elevated in borderline tumors? Tumor markers are not much elevated. Okay. Tumor markers usually remain normal or they are mildly elevated, like not like what we see in frankly malignant tumors. Okay. So, here we finish the discussion on epithelial ovarian cancer. We will see questions. What is systemic retroperitoneal lymphadenectomy? I have been continuously using this word, retroperitoneal lymph node dissection, retroperitoneal lymph node dissection, right? So, when I say retroperitoneal lymph node dissection, what does that mean? Up to what level should you dissect? That pelvic and para-aortic lymph node dissection is done up to what level? It is done up to the level of renal veins. Okay, it is done up to the level of renal veins. So, block dissection of lymph nodes from the pelvic side wall to the level of renal vein is retroperitoneal lymphadenectomy. Okay, see this question. A 49-year-old para 3 underwent laparoscopic left salpingo-oophorectomy for a complex left ovarian cyst. Histology shows a serous micropapillary borderline complex tumor, borderline ovarian tumor with the presence of DNA aneuploidy. What is the most appropriate management plan? See, here you would recall your knowledge on the treatment part of borderline tumor. I told you, for a borderline tumor, what you have to perform is a total abdominal hysterectomy, salpingo-oophorectomy, omentectomy, but what is not required is a lymph node dissection. You remember, this is what we saw under treatment of borderline ovarian tumors. If she has completed her family, you go for all steps, you do all steps that we usually do. If she has completed her family, you do whatever we do for a staging laparotomy in case of a frank malignancy, except for one point, that is lymph node dissection. Okay, the same thing has to be done because she is a 49-year-old lady, no? She is a 49-year-old lady, so she is likely to have completed her family by now. Okay, so what is done for her is only a salpingo-oophorectomy. What is done is only salpingo-oophorectomy, but it is borderline now. What is supposed to be done? The procedure has to be completed, no? Yes. So, total abdominal hysterectomy, right salpingo-oophorectomy, because the left has already been removed. So, right salpingo-oophorectomy, peritoneal washings, intracoelicomentectomy and exploration of the entire abdominal cavity. You understand? This is what is supposed to be done for this lady. Okay, so here we finish epithelial ovarian cancers. We will study some important MCQ points on germ cell cancers. Okay, so germ cell tumors, again they can be benign or malignant. Which is more common? 97% of the germ cell tumors are benign. Okay, 97% of the germ cell tumors are benign. And which is the most common? Teratoma. That means dermoid cyst. Okay, dermoid cyst is the most common. Okay, only 3% of them are malignant, and overall among all the ovarian malignancies, 10% of them are germ cell malignancies. Okay, so they involve first 2 decades of life. Okay, first 2 decades of life, they arise from primordial germ cells. They make only 10% of all ovarian malignancies. Okay, majority of the ovarian malignancies are epithelial ovarian malignancies, and germ cell malignancies make only 10% of all ovarian malignancies, and not all germ cell tumors are malignant. Most of the germ cell tumors are benign. Only 3% are malignant. And also remember, they are rapidly growing. Very, very important MCQ. They are fast growing. Okay, but that doesn't mean that they are more aggressive. Fast growing does not mean more aggressive. So, what is the most common complaint in germ cell tumor? The most common complaint is pelvic mass. Okay, and the most common site for distant met is lung. What? Lung. Okay, so here again, as we did for epithelial ovarian cancer, here again fertility sparing procedure can be done, and I will tell you where to do this fertility sparing procedure, in which stage we can do this fertility sparing procedure. Okay, so which is the most common germ cell tumor? The most common germ cell tumor is dermoid. The most common germ cell tumor is dermoid, okay, but the most common germ cell malignancy is dysgerminoma. So, hope you all understand the difference. Most common germ cell tumor is dermoid, whereas the most common germ cell malignancy is dysgerminoma, okay. So, most of the questions come from dysgerminoma only. Every time we keep getting questions from dysgerminoma. I'll tell you some important points on dysgerminoma. The first point is what? This is the most common germ cell malignancy, as we already studied, okay. What percentage of dysgerminomas are bilateral? 10 to 15% of dysgerminomas are bilateral. 10 to 15% of dysgerminomas are bilateral. Why is this point important? It's important because bilaterality is a feature of epithelial ovarian cancer, okay. Like say serous cystadenocarcinoma is 20 to 40% bilateral, and this is the maximum bilaterality we ever see, okay. Serous cystadenocarcinoma is 20 to 40% bilateral. Similarly, mucinous cystadinoma is 10 to 20% bilateral, okay. So, bilaterality is usually a feature of epithelial ovarian cancer, but not germ cell. But the only germ cell malignancy which has this high bilaterality is dysgerminoma. Among the germ cell malignancies, maximum bilaterality is seen with dysgerminoma, which is 10 to 15%, okay. But even then, unilateral lesions are mostly seen. Most of the lesions are unilateral lesions. Only 10 to 15% of the lesions are bilateral lesions, okay. So, what's the tumor marker for dysgerminoma? We've already discussed, no? The tumor marker is LDH and placental alkaline phosphatase. The tumor marker is LDH and placental alkaline phosphatase. We've been continuously getting questions on this, no? In 2018 AIMS exam, we had one question where a 19-year-old girl comes with a mass in the right ovary measuring 8 cross 8 centimeter with elevated LDH. What is the diagnosis? So, just simple question. 19 years, young girl, pelvic mass, elevated LDH. What is it? Dysgerminoma. You understand? So, what is the tumor marker for dysgerminoma? LDH and placental alkaline phosphatase. What's the incidence of bilaterality? 10 to 15%. Okay. And what is the chromosomal abnormality associated with dysgerminoma? It is the chromosomal abnormality associated with dysgerminoma is gain in 12p. The chromosomal abnormality is gain in 12p, okay. And also remember, dysgerminoma is the counterpart of seminoma in males, okay. There in males it is seminoma, here in females it is dysgerminoma. There it arises from the testes, here it arises from the ovary. And now I am stressing on this point because dysgerminoma does not always arise in a normal gonad. Dysgerminoma can also arise in a dysgenetic gonad. Dysgenetic gonad means an abnormal gonad, okay. Like we studied disorders of sexual differentiation, we studied primary amenorrhea, and there we studied a syndrome called Swires, we studied something called mixed gonadal dysgenesis, androgen insensitivity syndrome, Turner's syndrome, okay. And we know in Turner's and Swires are associated with non-functioning gonads or dysgenetic gonads, and they are at risk for malignancy. Even though in androgen insensitivity syndrome, the gonad is a functioning gonad, it's an undescended gonad, and that again is at risk for malignant change. And the usual tumor that arises is gonadoblastoma, which is a benign tumor, but later on this gonadoblastoma can turn into a malignant one like dysgerminoma. You understand my point? Okay. So, 5% of dysgerminomas arise from dysgenetic gonads. Not all dysgerminomas, only 5%. Okay. So, 5% of dysgerminomas arise in dysgenetic gonads. Okay. So, if you ask me, should we perform karyotyping in all young girls to see if the gonad is normal, or if the girl carries Y karyotype like how we see in mosaic Turners or Swires? Phenotypically they are females. No, Swires, mosaic Turners and all, phenotypically they are females, but then they have Y chromosomes. No. So, should we karyotype all women with dysgerminoma or all girls with dysgerminoma to see if there is any Y chromosome present? The answer is if the person presenting with a tumor has some abnormal sexual differentiation, okay. if the person is premenarcheal, if she has not attained menarche yet, if she has not attained menarche yet, if she is premenarcheal, or if there is a discrepancy between her breast development and pubic hair development, like how we see in Swires, okay. So, these are if there is any abnormality in the sexual development, and if you suspect some disorder of sexual differentiation like Turner's or Swires, then yes, you have to. And for all girls who haven't attained menarche presenting with dysgerminoma, yes, you have to perform what? Karyotyping, okay. So, very important MCQ point, okay. So, these are points about dysgerminoma. I will tell you a few more points about teratoma and yolk sac tumor, okay. So, what is teratoma? Teratoma is one variety of germ cell tumor where we have mature and immature types, okay. So, mature teratoma is benign and immature teratoma is malignant, okay. Mature teratoma is benign, immature teratoma is malignant, okay. And under mature teratoma, we have solid and cystic varieties, okay. So, what is dermoid cyst? We often use this word dermoid, no? Yes, in fact, dermoid is the most common germ cell tumor. Overall, most common germ cell tumor is dermoid, yes. So, what is a dermoid cyst? Dermoid cyst is cystic mature teratoma. Mature cystic teratoma is otherwise called dermoid, okay. Mature cystic teratoma is dermoid. You understand? Okay. So, remember, pure teratomas make less than 1% of all teratomas, and usually these teratomas are mixed types. Mixed type means teratoma plus yolk sac tumor, teratoma plus dysgerminoma, like that. Okay. Usually they are mixed varieties. Okay. So, the unique feature of germ cell tumor is that they more often are mixed varieties, okay. The one germ cell tumor coexist with the other, and the most common combination of mixed germ cell tumor is this very important MCQ. Most common combination of mixed germ cell tumor is dysgerminoma plus yolk sac tumor. What is yolk sac tumor? Yolk sac tumor is endodermal sinus tumor. Okay, yolk sac tumor is endodermal sinus tumor. Very, very important MCQ. Okay, most common combination of mixed germ cell tumor is dysgerminoma plus yolk sac tumor. Okay, so we learned some points about yolk sac tumor. Yes, okay. I want you to remember 5 points about yolk sac tumor. Point number 1, yolk sac tumor has the worst prognosis among all the germ cell ovarian tumors, ovarian malignancies. Yolk sac tumor has the worst prognosis, okay. High rates of recurrence and low survival, that's what's meant by worst prognosis, right. So, worst prognosis, high rates of recurrence, and most importantly, very, very important point, they are 100% unilateral, okay. A bilateral yolk sac tumor has never been reported till now. It is 100% unilateral, and it more often arises in combination to dysgerminoma, okay. 100% unilateral. Schiller dual bodies are specific pathological or histological findings that you see in yolk sac tumor, okay. So, I think about these specific histological points you would have studied in pathology. I don't want to bore you here. So, treatment part is what I am concentrating on. 100% unilateral, it is yolk sac tumor. Schiller dual bodies are seen in yolk sac tumor, and the tumor marker is alpha fetoprotein and alpha-1 antitrypsin, which I have already told you. Okay, so these are the 5 points you have to remember about yolk sac tumor. About tumor markers for epithelial ovarian cancer, I told you it's CA125. For mucinous adenocarcinoma, it's CEA and CA199, right? The tumor marker for dysgerminoma is LDH and placental alkaline phosphatase. For endodermal sinus tumor or yolk sac tumor is otherwise called as what? Yolk sac tumor is otherwise called as endodermal sinus tumor. Yolk sac tumor is otherwise called as endodermal sinus tumor. Okay. So, yes, yolk sac tumor, the tumor marker is alpha fetoprotein and alpha-1 antitrypsin. For Embryonal cancer, which is again a kind of germ cell tumor, it is alpha fetoprotein and HCG. For choriocarcinoma, it's HCG. I think I told you all these. Yes. But the important germ cell tumor which is non-secretory in nature or which doesn't have any tumor marker is teratoma. Okay. So the question is very simple. Which germ cell tumor is non-secretory? Which germ cell tumor is non-secretory? Which germ cell tumor has no tumor marker? Which germ cell tumor has no tumor marker? Which germ cell tumor is non-secretory? What would your answer be? Your answer should be teratoma. All types of teratomas, regardless of whether it's mature or immature. Okay, this is a very important MCQ. Which GCT is non-secretory? Teratoma. Okay, fine. So, this is it. So, finally, I will tell you something about a syndrome called growing teratoma syndrome. Growing teratoma syndrome. Okay. So, what's this growing teratoma syndrome? Growing teratoma syndrome is where when you treat a patient with chemotherapy for immature teratoma, mature teratomatous components grow simultaneously. Okay. Growth of mature teratomatous components during chemotherapy for immature teratoma is growing teratoma syndrome. Okay, mature elements. Fine. So, obviously the tumor markers would remain normal because I just told you, no, teratoma is non-secretory. Okay, so tumor markers would remain normal and this is benign variety, I mean benign flare up. Okay, malignant cells do not grow, only the benign cells grow. Okay. And therefore, they will not respond much to chemotherapy and all. In fact, chemotherapy is not required because they are mature elements, no? Yes. So, what it requires is only what? Surgical cytoreduction. Okay. If it grows, you have to remove them surgically. Surgical cytoreduction is what is required. Okay. This is about growing teratoma syndrome. Okay. So, finally, we will discuss about the management part of GCT. Yes. Okay. See here, GCT involves young girls, no? GCT involves teenage girls, mostly, young girls. So, what's the problem here? They will more often require what? Fertility sparing surgery. They will more often require fertility sparing surgery. So, when we studied the management of epithelial ovarian cancer, I told you fertility sparing surgery can be done for 1 year. That's unilateral salpingo-oophorectomy with other steps of staging laparotomy. Yes or no? So, here where can we do fertility sparing surgery? Where can we do that unilateral salpingo-oophorectomy? The answer is 1A and 1C. Okay. So, where can we perform a fertility sparing surgery? Very, very, very important MCQ point. Okay. Fertility sparing surgery can be done for 1A and 1C. There, in case of epithelial ovarian cancer, it can only be done for 1A. Here for 1C again you can do. Okay. So, what is that fertility sparing surgery? Like what we studied in epithelial ovarian cancer. All steps of staging laparotomy will be there except TAH with BSO. Okay. That means omentectomy, ascitic fluid for cytology, lymph node dissection, everything will be there. But the TAH with BSO will be replaced by unilateral salpingo-oophorectomy. This is the fertility sparing procedure. Fertility sparing procedure. Okay. So, the only difference is what? Here for 1A and 1C both, you can perform a fertility sparing procedure. Rest all are the same as what I told you for epithelial ovarian cancer. That means, perform a complete staging laparotomy and then if the stage is 1AB high grade or any 1C, give adjuvant chemo. For stage 2 to 4, see the operability, see the possibility of effective cytoreduction or optimal cytoreduction. If you can give an optimal cytoreduction, then go for a primary cytoreductive surgery followed by adjuvant chemo. If you cannot give an optimal cytoreduction and if it involves lung parenchyma, liver parenchyma, splenic parenchyma, all these, then you go for chemo first. Okay, neoadjuvant chemo for 2 to 4 cycles. Then you perform a surgery, interval cytoreduction and then go for adjuvant chemo for another 3 to 6 cycles. You understand? So, this is what you are going to do here again. Okay. So, here also you have to do a lymph node dissection as a part of staging laparotomy. Okay, so fine. Now, basically all germ cell tumors can involve lymph nodes like this germinoma, yolk sac tumor, teratoma, all these can involve lymph nodes, but the highest nodal involvement is seen in which germ cell tumor? That's a very important question. Highest nodal involvement. Which malignancy? Dysgerminoma. Okay. Highest nodal involvement is seen in dysgerminoma. Second is, which is the worst of all germ cell tumors? I've already told you this point. Worst of all germ cell tumors. Yes. Yolk sac tumor or endodermal sinus tumor. Okay. Worst of all germ cell tumors. So, I told you, no, for stage 1A, B, grade 1, 2, there is no need for adjuvant chemo. From 1C onwards, 1AB grade 3 and 1C onwards, you have to give adjuvant chemo. I told you this when we discussed epithelial ovarian cancer, and the same is applicable for germ cell cancer as well. The only exception is yolk sac tumor, where you have to give chemo for all stages. Okay, all stages will require chemo in yolk sac tumor because yolk sac tumor is the worst of all germ cell tumors. It is associated with a bad prognosis. Bad prognosis. Okay. So, you understand, no? Yes? So, yeah. Now, we have a question here. We have few questions with which we can end our session. Okay. Regarding ovarian germ cell tumors. Now, this is a true or false kind of thing. The majority are malignant. Is it correct? No. Majority are benign. Only 3% of them are malignant. Okay. The most common malignant germ cell tumor is dysgerminoma. This is correct. Premenarcheal patients should undergo karyotyping. This is correct. HCG and LDH are useful tumor markers. This is again correct. When you suspect germ cell tumor, basically this tumor marker will tell you whether it is dysgerminoma or any other tumor tumor like choriocarcinoma and all. So, for that you have to obviously perform all tumor markers. Okay. So, the presence of LDH and the absence of HCG will tell you that it is dysgerminoma. You understand? So, what is the answer here? All are true. No. All are true except one. Yes. Okay. See the next question here. 18-year-old unmarried girl presents with abdominal distension 20 days. 18. Pain abdomen and 1 week. Ultrasound reveals 8 cross 8 cm solid mass in the normal head. Next on further examination, all markers are normal except LDH, elevated LDH. So, obviously, this is what? Dysgerminoma. Dysgerminoma. Okay. Most often, majority are bilateral. Majority are bilateral. What do you feel about this option? Are they bilateral more often? They are more often unilateral. Okay, very few are bilateral. They are more often unilateral. 10 to 15% of them are bilateral. Excellent chemosensitivity is correct. I didn't tell you this point. Dysgerminoma is highly chemosensitive. It's highly radiosensitive. Okay, it's highly chemosensitive. It's highly radiosensitive. Karyotyping is mandatory for premenarcheal, but here it can be taken as correct because already one statement is obviously wrong. Okay. Fertility sparing procedure can be done in early stages, 1A and 1C, yes, you can do. So, the wrong statement is A, majority are bilateral or wrong, okay, majority are unilateral. Most common combination of mixed germ cell tumor is dysgerminoma plus yolk sac tumor, okay, dysgerminoma plus yolk sac tumor, okay. So, we have another question from yolk sac tumor. Regarding yolk sac tumor, recurrence rate is very high. That's correct. It's a very dangerous tumor. Recurrence rate is high. Elevated alpha-1 antitrypsin is correct. Alpha-fetoprotein and alpha-1 antitrypsin are 2 tumor markers for yolk sac tumor. Arise from dysgenetic gonad? No. Which one arises from dysgenetic gonad? Dysgerminoma. Okay. Carl-Exner bodies and coffee bean nucleus are features of granulosa cell tumor. They are not features of yolk sac tumor. Okay. Here we are not going to discuss Escott stromal tumors. We will stop with germ cell tumors here, but then I am telling Carl-Exner bodies and coffee bean nuclei are features of granulosa cell tumor. They are 10% bilateral? No. Again, they are 100% unilateral. Okay, they are 100% unilateral. Schiller dual body is a feature of yolk sac tumor. Okay. So, 1 is correct, 2 is correct. Arise from dysgenetic gonad, 3 is wrong. 1, 2 and 6. Yeah. 1, 2, 6 are true here. Okay. See this question. A 19-year-old woman presents to the emergency department with lower abdominal pain and swelling that she has had for 4 days. Irregular pelvic abdominal mass of 15 centimeter in a 19-year-old girl. What comes to your mind first? 19 years abdominal pelvic mass. Dysgerminoma. We'll see. Her LMP was 2 weeks ago. Transabdominal ultrasound shows features of ovarian neoplasm. Okay, so this is more likely to be dysgerminoma. You have dysgerminoma in your mind when you answer these questions because that's the most common. This is most likely an ovarian germ cell tumor. This is correct. Yes, it is an ovarian germ cell tumor. Most ovarian germ cell tumors are benign. Again, correct. Most ovarian germ cell tumors are benign. Okay. Because the history is very short, it has developed over 4 days. I am thinking in terms of dysgerminoma, but it can still be teratoma. But remember, the statement says general statement. It is a general statement. Most ovarian tumors are benign. Correct. That's correct. Her preoperative serum CEA and CA19 should be assessed. Oh, no. When you strongly suspect a germ cell tumor, what gets priority is LDH, alpha-fetoprotein, antitrypsin, PLAP, all these. Normal tumor marker levels do not preclude a malignant ovarian germ cell tumor. That's right. Tumor markers are not always elevated. I already told you, they're not diagnostic. They only have prognostic value. They're not diagnostic. Most of them, even I told you, in stage 1 ovarian cancer, 50% of the women will have normal markers. Okay, will have normal markers. Okay. Most immature teratomas are tumor marker negative. This again is correct. I told you, no? Yes. Teratoma is non-secretory. Teratoma has no tumor marker at all. Okay. So, A, B and here A, B and D are correct. See, this is an old PJ pattern question, but yes, it's worth learning. Okay. Now, yeah, C and D. A, B, C, D are correct. There are 2 C options, B options here. So, this is a typo error. This take it as C, take it as D, take it as E. Okay. So, I would say A, B, C, D and E are correct. Which is false? C is false. C is false. Is it clear now? Yes? Okay. Now, see the next question. The same woman described in the preceding question now undergoes a laparotomy. This dysgerminoma undergoes a laparotomy. Her preoperative tumor markers were all in the normal range. Right ovarian solid cystic mass 9 cm with smooth intact capsule 6 cm. Left ovarian solid cystic mass with smooth intact capsule. So, it's a bilateral tumor. Bilateral tumor. The tubes in uterus are normal. The intraperitoneal survey is normal. Which of the following is true regarding her management? Okay. So, bilateral dysgerminoma. Okay, we will see the options. Ovarian dysgerminomas are usually bilateral. Wrong. They are usually unilateral. Only 10 to 15% of them are bilateral. Okay. A contralateral dermoid cyst may be found. Yes, that's correct. Contralateral dermoid. Germ cells can occur in any combination. Any combination. Dysgerminoma plus dermoid, dysgerminoma plus yolk sac tumor, dysgerminoma plus teratoma. Anything. Okay. Bilateral oophorectomy and lymphadenectomy should be carried out. Bilateral ovarian cystectomy should be carried out. Chemotherapy may be required if the histology is malignant. Okay. Now, bilateral oophorectomy and lymphadenectomy versus bilateral ovarian cystectomy. Which should be done? Which should be done? You strongly suspect malignancy and you very well know that you have to perform a staging laparotomy even if it's a fertility preserving surgery. The only exception is you can spare tube, you can spare the uterus and one ovary if it's unilateral involvement. But here it's frankly bilateral. It's frankly bilateral. Okay. So, you can't perform a fertility preserving surgery here. Okay. So, definitely you have to remove both the ovaries, no? Definitely you have to remove both the ovaries and the tubes. Bilateral oophorectomy and lymphadenectomy. should be carried out and not a simple cystectomy. Simple cystectomy would not help. Okay, you have to do a lymph node dissection. Okay, chemotherapy may be required, that's correct. Only after you finish the surgery, you will come to know what stage it is, and then you will decide on whether to give chemotherapy or not. So, may be required, yes. Growing teratoma syndrome, okay, contains immature teratomatous components. Is it correct? It contains mature elements. It contains mature elements. It is a malignant condition? No, it's a benign condition. It's a benign condition, okay. Tumor markers are normal, that's right, okay. For any teratoma, tumor marker remains normal, and here again it's the same. Tumor markers remain normal. Chemotherapy is the treatment of choice? No. When it's not malignant, why would you go for chemotherapy? Yes, the treatment of choice is what? Surgical debulking, okay. Surgical removal is the treatment of choice, okay. So, the only correct option here is normal tumor markers. All other options are wrong, okay. So, here we finish germ cell tumors. Like this is a rapid revision of what all you have to know when you handle a case of or an MCQ on germ cell tumors, okay. So, we will stop here. I hope you have some idea on how to approach a case of ovarian cancer in your MCQ now, okay. Since this is a revision program, I am not discussing sex-cord stromal tumors, epithelial ovarian cancer, germ cell cancer. I hope you are all thorough with the management part and few important MCQs.